Hi everyone, I am Dr. Sashikant. I am back with a very important topic, chronic lymphocytic leukemia. You can expect number of questions from this particular topic. So please subscribe to the channel, like and comment on the video, and please stay hooked to the video till the end. We have a case discussion at the end of the presentation that will clarify all your concepts regarding this particular topic. So certain important points that you need to remember regarding the chronic lymphocytic leukemia or CLL. It is a disease usually of elderly individual, but the disease can occur even earlier also. But most commonly, it is the age of occurrence is 60 year above 60 year of age. Overall, it is the most common leukemia in the United States and the Western world is the most common cause of generalized lymphadenopathy. So when we use the word generalized lymphadenopathy, so it means presence of two or more than presence of more than two group of lymph nodes, non-contiguous group of lymph nodes. Their enlargement, if it is present, we call it as generalized lymphadenopathy. It's also called as small lymphocytic leukemia or lymphoma if it is confined to the lymph nodes or organs without peripheral blood lymphocytosis. So if there is no lymphocytosis in the peripheral blood, but if it is confined to some lymph node or some organ, then we can call it as small lymphocytic lymphoma rather than chronic lymphocytic leukemia. And many of the times, these two terminologies, CLL and SLL, are used interchangeably at many of the places. So it's a malignant neoplasm of virgin B cell that you need to remember, often being asked. So it's a B cell neoplasm. Okay. The tumor cells cannot differentiate into plasma cells. So the maturation of tumor cells, maturation of the B cells beyond uh, the mature B cells is arrested. So the B cells cannot transform into the plasma cells. So that results in overall hypogammaglobulinemia. So this is the key feature, and many of the complications they do arise because of this hypogammaglobulinemia due to lack of maturation of B cells, neoplastic B cells into mature B cells. There is overexpression of anti-apoptotic BCL2 and BTK gene and protein that is being seen in many of the cases. Additional chromosomal abnormalities like deletion 13q, 11q, 17p, trisomy 12q may be seen. Even Notch1 mutation may also be seen, and all these have implications in the overall prognosis of the patients. So these neoplastic or mature looking B cells, they proliferate and accumulate in the bone marrow and peripheral blood. So bone marrow and peripheral blood lymphocytosis is a salient feature of chronic lymphocytic leukemia that you need to remember. So the tumor cells have the B cell markers, pan B cell markers like 19 and 20 are uniformly expressed. But the important feature that differentiates it from other type of uh, lymphomas, other type of lymphoproliferative disorder is the T cell marker expression. So aberrant T cell expression of CD5 is seen in CLL. Clinical findings often asymptomatic, non-specific, easy fatigability, weight, anorexia are seen. Generalized lymphadenopathy, as we discussed, is seen. Hepatosplenomegaly may be seen in the patients where the tuber burden is excessively high. Then hepatosplenomegaly may be encountered. Autoimmune hemolytic anemia and thrombocytopenia. Now, this you need to remember. This may be seen in many of the patients due to various abnormal immunoglobulin, various antibodies that are produced by the non-neoplastic cells against RBCs and platelets. So, though there is generalized hypogammaglobulinemia, but it is believed that some abnormal immunoglobulins are produced which are directed against RBC and platelets, leading to their premature destruction and causing autoimmune hemolytic anemia and thrombocytopenia. Usually, the autoimmune hemolytic anemia is due to the presence of cold agglutinin or IgM type of antibodies. Infections are seen owing to the generalized hypogammaglobulinemia due to non-maturation of T cell into plasma cell, as we discussed. So this is very important. You need to remember that, and your questions are basically concentrated on that. That infections, many of the patients they do die because of generalized infections. Many of their morbidity and mortality is due to the infections owing to hypogammaglobulinemia. This is a very important catch of chronic lymphocytic leukemia. WBC count is generally elevated. It may range from 15,000 to up to 200,000 per cubic millimeter. Absolute lymphocytosis, the criteria is that it should be more than 5,000 lymphocyte per cubic millimeter is seen. And the lymphocytes are usually mature lymphocytes with scant ream of cytoplasm is seen. And one of the important key feature is the presence of smudge cell. So these neoplastic cells, many of these neoplastic cells, they become fragile. So while preparing the peripheral smear, they get the cytoplasm usually get frayed away, and they have a very irregular margin, frayed margin, that is called as smudge cell. Normocytic anemia and thrombocytopenia is seen. Bone marrow findings show replacement by neoplastic B cells. Hypogammaglobulinemia is a common feature. So you can see the neoplastic cells are all small lymphocytes with a very scant ring of cytoplasm being seen over here. And you can see some uh, spirocytes. So spirocytes which are seen can be seen due to hereditary spirocytosis, or it can be seen in any of the acquired hemolytic anemia cases. So here they are quite round and round in shape rather than the biconcave, and you can see the lack of central pallor, that is the characteristic of spirocyte. And the one which I was talking about is the smudge cell with irregular broken edges, that the broken edges and irregular cytoplasmic boundary, that is known as smudge cell, or sometimes even known as basket cells as well. And another feature of hemolytic anemia, that is nucleated RBCs or NRBCs, normoblast can also be seen occasionally in peripheral blood smear. So coming to the natural history and treatment, usually the median survival is 4 to 6 years. But many of the CLL patients, they do live beyond 10 years, especially if the tumor burden is less. And as I told before, so here again I emphasize that 50% of the cases they do die because of overwhelming infections owing to hypogammaglobulinemia due to non-maturation of plasma cells. Treatment is directed against B cell marker, that is monoclonal antibodies against CD20, BCL2 inhibitor, and BTK inhibitors have been tried in treating these patients with a variable degree of uh, success in treating these cases. And some of the important complication of CLL is that some of the CLLs, they do transform into more aggressive disease. So please remember this. This is often asked. There may be a transformation into Richter syndrome, so-called Richter syndrome, which is nothing but a transformation of CLL into a diffuse large B-cell lymphoma or DLBCL. This could be asked. And even there could be transformation into another type of lymphocytic proliferation, that is pro-lymphocytic leukemia. So Richter syndrome, pro-lymphocytic leukemia, these are important complications of CLL that you need to be aware of. So let's wind up the presentation. Let's end with an important case discussion, which will definitely clarify your concepts. So a 62-year-old man, initially seen in urgent care department because of sore on medial surface of left ankle. On examination, patient is afebrile, erythema, and induration of anterior portion of both lower extremities is seen below the knee. Patient is diagnosed with cellulitis and observed in the hospital because of high leukocyte count is seen. And despite receiving 48 hours of IV antibiotics, and leukocyte count remains elevated, and he is discharged and completes a 10-day course of oral clindamycin. He returns to the urgent care center for follow-up, completing the antibiotics. At that time, the appearance of the lower extremities unchanged, and serum leukocyte count again remains elevated. A peripheral blood smear shows mature lymphocytosis. So what is the tentative diagnosis? So here, as you can see, the key features: elevated count, and there is various infection, cellulitis is there, and elevated leukocytosis elevated leukocyte count is still persisting after antibiotic therapy, and the person is 62-year-old. So, and another catch is very important catch is the peripheral blood smear shows mature lymphocytosis. So, all these features indicate the presence of chronic lymphocytic leukemia, which is very common malignancy in this age group. So, 62-year age group, cellulitis, high elevated leukocyte count, WBC count, peripheral lymphocytosis, persistent elevated WBC count. So all these are in keeping with chronic lymphocytic leukemia. So that's how you need to approach various questions regarding chronic lymphocytic leukemia. So that's all for this particular presentation. Hope you like the presentation. Stay till the end of the presentation. And it is very important to clarify the concept, and uh, please try to listen to this this video again and again to recapitulate the concepts well. And see you all in another video. And please subscribe and uh, do your and keep your valuable comments in the comment section. So thank you all.